Punctal occlusion is a mainstay in the contemporary dry eye practice. Yet with so many advances in therapeutics, it may have made the decision on when to perform punctal occlusion even more difficult. So the question becomes, when is occlusion appropriate for our dry eye patients? We hope to provide a targeted answer to this question on what we have found to be a successful strategy. Many of us have heard of the analogy of the tear film in a dry eye patient being equated to a sink filled with dirty dishwater. This is because of the high levels of inflammatory mediators in the tear film of our dry eye patients. As such, we've been taught to essentially clean up or decrease the inflammation of the tear film so that it's analogous to clean water that's entering the sink. At this point, it would seem more reasonable or make more sense to then retain the healthy tears on the ocular surface with punctal occlusion. But clinically, we're challenged with deciphering inflammation and when it is appropriately reduced. Certainly, most would agree that the eye on the left is severely inflamed. But does the right eye have significant inflammation, and is a punctal occlusion warranted? It's certainly difficult to tell simply based on physical inspection. A dry eye patient has increased levels of inflammatory proteins in their tear film. One inflammatory marker that's elevated in patients with ocular surface disease is matrix metalloproteinases, or MMP9s. A normal level of MMP9s on the ocular surface is 40 nanograms per milliliter or less. With ocular surface disease, including dry eye, you're likely to have elevated levels of MMP9s above this concentration. A point-of-care test now gives us the ability to assess the ocular surface for increased levels of MMP9s. This test, called Inflammidry, will tell you whether or not there is greater than or less than 40 nanograms per milliliter of MMP9s in the tear film. A blue line is the control line and shows that an adequate level of sample has been acquired. A red line means that there is greater than 40 nanograms per milliliter of MMP9s in the sample. Because the darkness of the red line is based on the amount of MMP9s in the tear film, the strength of the line may vary with varying concentrations of the inflammatory marker. We actually grade the strength of the red line as either a strong positive or a weak positive, as can be seen here. As with any inflammatory condition, the goal is to decrease inflammation and thus the level of MMP9s on the ocular surface. Fortunately, we have a number of ways to do this with both topical and oral therapeutics. Over time, through successful treatment, patients will have less inflammation on the eyes, ideally less than the threshold of the test, giving a negative result. Confirming a reduction in MMP9s will then give you a targeted approach on when to consider punctal occlusion for your dry eye patients. Remember that punctal plugs are an important part of managing dry eye patients. Also remember that their use can now be targeted by measuring ocular surface inflammation. And if significant inflammation is present, consider decreasing inflammation. Then, when inflammation has subsided and its reduction has been confirmed with point-of-care testing, punctal occlusion should be considered. Keeping these things in mind will help improve patient outcomes, which is ultimately why we do what we do. We hope that this has been clinically insightful.